So now you go face down, please, with your neck, please.
There's point if someone did have Botox, would you have less tension there? Because the muscles. Someone did have
Yes, you don't feel the bone. You don't feel it.
Okay.
You cannot treat it because
Okay.
what happened that the relationship within fascia and muscle is very connected. So if you do the Botox, the muscle is totally relaxed, you will not feel the insufficiency. The insufficiency is there. So after 3 months, when the effect of Botox is gone, the patient starts to have pain again. Now, example, in Brazil, there are many physicians that inject Botox for migraine. But it's not resulting because after 3 months, the symptoms go back. And because of compensation, they start to have more neck pain. Okay?
So interesting, I used to use it, but usually it's more centered and paralysis.
Yes.
And usually it's 2 points
Yes.
here.
Yes.
And after 2 or 3 treatments, after 1.5 years, usually it's less.
But
Because
you
it's
have, to
like-
keep, but you have to keep doing the treatment.
Yeah, for sure.
Yes.
So,
It could, but the problem is that if the patient had other reason for that, example, TMJ has a huge association with emotional aspect. So what happens if you block here, the patient will start to have compensatory movement. So they start to have pain somewhere else. Maybe not here anymore, but somewhere else. We see a lot, example, the people that do in Brazil they do a lot, the facelifting, the surgery for the skin. So maybe they do the surgery, you palpate here, you don't feel nothing. The patient start to have headache on the parietal part because of the anchorage point of the surgery. So you always have to, this is why when we do the interview after, you have to ask also about plastic surgery. Because plastic surgery give a lot of, more problems sometimes than orthopedic surgery for pain. Because a patient don't understand this connection sometimes because it's a plastic surgery, so it's not important. Now, point number 3, you have this position is good, or even more, yes, perfect. So, you palpate the occipital protuberance, okay? You go a little down and lateral, you are at the base of the skull, over the occipital bone, over the occipitalis muscle, suboccipitalis muscle. And you can just go with the knuckle towards the occipital bone and check here. This is very, very important for headaches. Most of the time during the treatment, this point irradiates towards the eyes. Very, very common because also the occipital nerve here. So it's very common that you treat here and the patient feel the pain in the eyes. It can be very, very helpful for patients with migraine as well. When you treat a patient that have long hair, you should not glide over the hair, the high hair. So you have to open the space like this. If I want to treat here, I open the space a little bit, and then I treat. Because if I glide over the hair, I irritate the scalp. Next point, which is the neck. This position is good, or it can even be seated like this. We have to check the border of the trapezius. For the trapezius, we go at the level of C5 to C6. This point we don't approach with a 90 degrees approach, but 45 degrees, because we want to go below the trapezius and treat the erectospine. So it's like you go towards the transverse process. This is the transverse process that you go like this. C5, C6, C6, C7 sometimes. Check both space. And you go like this. Very important for neck pain. Again, here most of the time you have neck pain with irradiation towards the eyes. Now, we go to the next one, thorax. Place your hand along the trunk. We have to check. scapula, inferior angle. Okay. Scapula, superior angle. This point is over the rectus spine, more or less between the level of T4 to T6. This point, we say, is a functional point that changes according to the level of kyphosis of the patient. Probably the easiest way to visualize this. You palpate the spine, inferior angle, in the middle of the two, you go with the rectus spine. And you start to check it. More or less, if you count it, 2, 3, 4, 5, T6. Some people can be a little bit low, so between T4, T5, T4, T6, sorry. But over the muscle of the rectus spine, the muscle belly. So you have to feel the rectus spine. On Harris here, before. And for the treatment, you can go like this. With the knuckle, okay? Or you can go with the elbow. This. So you press the point, you reach the point, then you glide. Very important for upper thoracic pain, dorsalgia, and also neck pain.
No, I can survey somebody, you know. I can
Yes,
survey.
yes. You see that it's not, does not glide, exactly. The next one, we are on retrolonging, patient prone, palpate 12 ribs, floating ribs. Sorry. Too sensitive. Spine. We are here basically, more or less between T11 and L1. You can do like this. You can palpate the 12 ribs. Where your thumbs reach, the spine more or less is where you find the point. Okay, so here, usually we place ourselves posterior to the patient, more close to the feet, and going towards the head. Stabilize yourself, and then with the elbow, you start to this point. This point is particularly important for low back pain, sometimes even for the pain felt around the superior iliac and posterior iliac spine. Now this point has all the point in the part of the low back. Usually you have less tensification and more muscle contraction. And most of the time the real problem is here in the glutes, the pelvis region. So it's like what we said for the migraine. We don't start from the head. So if the patient has low back pain, at least start from the coxa and pelvis region. So glutes and pelvis, and then move upwards. Remember this slide yesterday, we showed that example. This is, let's say this is the thoracolumbar fascia. This thoracolumbar fascia is totally connected with the glutes fascia. Okay? So if the glutes fascia is tight, push the thoracolumbar fascia, activate the receptor here. The patient feels the problem here, but the real problem is lower. Okay? Now the next one I bring lower a little bit here, okay? Here you have to palpate PSIS, sacrum, now here we have to check. The retrospine become narrow here, okay? So you use as a margin PSIS, the retrospine, and the iliac crest. And the point is in this area between PSIS, lateral border of the retrospine, because the real target for this point is the iliolumbar ligament that is here, but not in all the people you are able to palpate here, especially if there is more adipose tissue, it becomes difficult. The best way is to use as a target the lateral border of the spine. This way you will go towards the iliolumbar ligament without having to worry to feel the ligament itself. So you can do a direction that is more like oblique or diagonal. So this is imagine that your direction of treatment is this way. You can place, example, your elbow here, and go. Place the elbow. Now you have to angle the elbow to use more the olecranon, and you go towards the lateral border of the rectus spine. And you can feel very well here. And here you have the lumbar ligament, but also the proximal part of the QL, parallomborum. You have the posterior layer with thoracolumbar fascia. So it's an area of connection of different muscles. And this is very important for low back pain, sometimes give radiation towards the lower limbs.
Does this feel like a side joint pain?
Yes, a lot. A lot. A lot. No? Here, radiations and a deep pain in the low back, usually. And remember, most of the time the patient tells you, look, I have pain over the PSIS. You go here, there's nothing here. It's this point that creates pain over the sacral joint. Okay. Now for the next one, I need you to go sideline, please. To one side, you can decide the side.